Now with Professor 𝐏𝐫𝐸, he will present HER2 metastatic breast cancer treatment paradigm.
شكرا جزيلا، كل سنة وانتم طيبين. يعني first of all طبعا I would like to thank my dear colleague Dr. Ahmed and my dear Professor Dr. Adina for the invitation. It's always a pleasure to be there with a very educational agenda. I always like the agendas that are prepared by you that have a very comprehensive way of looking at the whole spectrum of the disease. قبل ما ابتدي المحاضرة بتاعتي بس I would like to concur على معلومة مهمة قوي. أنا I think we have different specialties هنا، ويمكن ناس لسه ممكن هيبقوا specialized في حاجات معينة. And I think the most important presentation today was a presentation by Dr. Shadi. We are going to talk, Dr. Ahmed Magdi اتكلم على very expensive medication. I'm going to recycle the same medications in the metastatic phase لأن الأدوية بتتحرك مكانها مع الوقت. But again, we're going to talk about medications that cost millions of Egyptian pounds. And الديسيجن ده اللي هو decision مؤلم for any payer is going to be radically affected by the pathology and the specimen. ولأسباب اختلاطي بأمور إدارية معينة الفترة دي I can يعني concur, and the most important problem nowadays هو الفورمالين اللي ب3 جنيه ونص. inappropriate fixation كتايمنج، ان انا بس بعرف ان انا احط الحاجه دي بعد قد ايه من طلوعها من جسم البني ادم، وان انا اعمل appropriate fixation بفورمالين 10% حاجه extremely cheap. للاسف احنا بنسيب ده لشخص نون ميديكال هو بيعمله، العامل او العامله اللي في اوضه عمليات او في الانترفنشن راديولوجي، وده هيؤثر تاثير جذري على اللي الدكتور شادي هيشوفه واللي الدكتوره وفاء هتشوفه بعد كده in the molecular testing. Cancer is now approved to be a genetic disease. We are looking at mutation. We personalize our treatment. ربنا عارفينها كلنا، اي حد دلوقتي بيجي بيبقى دايما looking at طب انا في حاجه ممكن ابعد عن الكيموثيرابي، في targeted therapy. We fail to do the appropriate testing because of the inadequate preservation of the samples. So again, we are agents of change in our places, and I think this is the most important message you need to remember today. لو ركزتوا في الكلمة دي مش مهم المحاضرة اللي هقولها بعد كده هقلبها في 10 دقايق. So for the HER2 metastatic breast cancer management, again, Dr. Shadi and Dr. Ahmed have explained very well the pathological assessment of HER2 and HER2 testing, and Dr. Ahmed have also explained the different mechanism of actions of the different agents that we're going to use. And now we're going to look rapidly on the clinical trials and how they affect the standard of care. The standard of care for metastatic breast cancer for a long time was very clear for us and very simple. We had the Cleopatra trial for a very long time, stayed as a standard of care, وما زال هو the standard of care, with the use of doublet anti-HER2, trastuzumab and pertuzumab, combined with docetaxel versus older protocol, which is trastuzumab plus docetaxel, and then we have an overall survival benefit. And then we had the Emilia trials that have showed that the best second-line treatment after progression on trastuzumab or progression on trastuzumab plus pertuzumab is to use TDM1 اللي هو الكاتسايلا, which is one of the antibody drug conjugates. So progression on trastuzumab chemo, the second line is not to add pertuzumab, is not to add a doublet anti-HER2. The second line is TDM1. We have tried also to de-escalate chemotherapy and tried to give trastuzumab plus pertuzumab with metronomic oral cyclophosphamide or alone. This is a small phase 2 trial, and as you can see, you don't see the same overall survival benefit we have seen in the Cleopatra trial. This is also another Chinese study that have looked at a different combination, similar to the Cleopatra, very similar, but using another drug called the pyrotinib. Here you can see that you have a progression-free survival benefit and a trend for also overall survival benefit. But again, because it's a Chinese study and came a little bit late after Cleopatra trial was a standard of care, it was not adopted in European and American settings. And then we have a very old study, but a very effective combination for heavily pretreated patients who received anthracyclines and taxanes and anti-HER2 treatment with trastuzumab, which is the use of lapatinib plus capecitabine, which is approved and reimbursed in our system, versus capecitabine alone, and you can see that we have a progression-free survival benefit. There has been also other trials of doublets combining lapatinib plus trastuzumab, and this is a chemotherapy-free regimen, and again you can see that you have an improvement in the progression-free survival in this patient. And again, this is one of the nice combinations that we can use if you want to avoid chemotherapy. And now we have also new tyrosine kinase inhibitors. Dr. Ahmed have been talking to you about the neratinib in the adjuvant setting. You can use it also as the same combination of capecitabine lapatinib. Using the combination of capecitabine and neratinib, you have a mediocre improvement in progression-free survival, so it didn't gain a lot of acceptance. But the new addition was the addition of tucatinib, again in patients who had progressed on previous treatment with trastuzumab, pertuzumab, and T-DM1. You have the HER2 study showing the addition of tucatinib to trastuzumab plus capecitabine have improved the progression-free survival and has also improved the overall survival with a hazard ratio of 0.66, meaning a 34% reduction in the risk of death. So, the other part that have shown that was the most interesting in the HER2 claim was the efficacy in those patients who have brain metastasis. You've been asking about the blood-brain barrier, and this is one of the most effective drugs that crosses the blood-brain barrier with a clear separation of the curves in terms of overall survival benefit. And again, it is one of the main indications that makes it in the list of medications that we can use in this combination. So again, we have tried also to add tucatinib to earlier lines of treatment. This is the HER2 2 that looked into adding tucatinib to the T-DM1 standard second line protocol. You can see you have a very small progression-free survival benefit. This benefit is higher with patients with brain metastasis, but again, the magnitude of benefit is not so high as has been seen in the HER2 01 trial. And as you can see, there is no overall survival benefit, also some objective response rates. So really, if you have a patient that is highly symptomatic from brain metastasis and you need to have a rapid response in the second line, you may consider the addition of tucatinib to T-DM1, but probably this is the only indication that could be of interest in this category of patients. And then we have the superhero of the HER2 positive metastatic breast cancer, which is the trastuzumab deruxtecan, a very effective and very potent, what we call an antibody drug conjugate, means the chemotherapy that is attached to an antibody against the HER2. And you have seen in the very early trials in polytreated patients, this is the waterfall plot, lines اللي نازلة تحت دولت patients that are responding after having failed on multiple lines of treatment. And as you can see, there's a very effective with a very high objective response rate. And the main toxicity that we are afraid of is interstitial lung disease that can happen in about 15% of the population receiving this drug. And this has led to the DB03 phase 3 trial, looking at patients previously treated with trastuzumab and taxanes in the metastatic setting. And this is a trial that compared trastuzumab deruxtecan to T-DM1. And again, important to understand the design of the trial. It's important to look into the protocol and the design of the trial, because this is not a trial that was looking at changing the second line and comparing to T-DM1 is the second line. This was to compare versus in efficacy in terms of efficacy versus T-DM1. So you had patients on second and third line and beyond that were recruited in this population. But as you can see, the difference in PFS is huge. We have a hazard ratio of 0.33. That means a 66 reduction in the probability of progression on the disease, and again, and also an improvement in the overall survival. And the updated overall survival of these patients have shown that for a long duration of follow-up, you have an overall survival benefit with a hazard ratio of 0.73, so meaning 27% reduction in the risk of progression. What sometimes we don't like to see is the banana-shaped curves. It means that after a long time, the difference decreases. I thought at the beginning that it means that after long follow-up, there is no big difference, but this is not true. If you want to understand the banana-shaped Kaplan-Meier curves, it means that you have a category of patients that will live longer because of the disease, but then you have about 40 to 45% of the patients who do very well on T-DM1, and that means that we need to look at biomarkers that are going to tell me who are those patients who do very well on T-DM1, meaning that we may offer T-DM1 if we don't have trastuzumab deruxtecan, and those other patients who actually do better when they receive trastuzumab deruxtecan at this time of point. Because again, the overall survival takes into consideration patients who have received T-DM1, and then when they progress, they receive trastuzumab deruxtecan. It doesn't mean that they didn't receive the drug. It means that they didn't receive it at this timing of intervention and in this population. Again, the major problem that you need to take care very much about it is the interstitial lung disease, which you can see in most of the ADCs, but it's more pronounced with trastuzumab deruxtecan. Early recognition is very important. Early treatment and early dose interruptions is very important to avoid losing a patient that may be very well responding to the drug, but may die from a toxicity that is quite fatal. So we also have the DB02 phase 3 trial, which randomized patient with metastatic breast cancer on the first line, the standard trastuzumab, on later lines, versus trastuzumab capecitabine TDXD, the trastuzumab deruxtecan, versus Herceptin capecitabine or trastuzumab capecitabine or lapatinib capecitabine. Again, you can see a progression-free survival benefit and overall survival benefit. So again, up till in 2026, we still have the Cleopatra trial, which is the standard of care for our patients, but now we have a new standard of care in the second line, which is the trastuzumab deruxtecan based on the DB03 trial. So can we optimize? Can we improve the Cleopatra trial? We can actually improve in multiple ways. In those who have hormonal receptor positive, we have the Patina trial, what looked to add palbociclib in the maintenance phase, so after chemotherapy, dual anti-HER2 treatment, the addition of palbociclib plus endocrinal therapy versus endocrinal therapy alone. What is important, there are two important messages in this trial. The first one is that we have a PFS benefit, but if you look at the control arm, those who didn't receive the palbociclib, we have a median PFS of 29 months. This is higher than the Cleopatra trial. Why? Because in the Cleopatra trial, there are patients with hormone receptor positive disease that did not receive anti-hormonal treatment and were maintained on anti-HER2 treatment alone. So it does mean that maintaining patient on hormonal treatment for hormone receptor positive, even in HER2 positive disease, we need to continue on maintenance hormone receptor, anti-hormone receptor, endocrinal therapy. So the other part is that we have a PFS benefit more than 14 months in benefit additional to the 29 months with the anti-HER2 treatment alone with endocrine therapy, but this didn't confer into an overall survival benefit, but probably because we need a longer time of follow-up to see the overall survival benefit. Again, we have also another trial, the HER2-CLIM-5, that again looking at improving the Cleopatra protocol with the addition of tucatinib. You can see we're trying to add tucatinib in multiple, in the early stage with Dr. Ahmed Magdi, and also in the first line treatment of HER2 metastatic breast cancer. And as you can see, we have a PFS improvement in this category of patient, but without real overall survival benefit. But again, what is important, you can see that the PFS for those patients with the Cleopatra trial protocol, we have a median PFS of 16 months, not like the 29 months we saw in the previous the previous study with palbociclib, but because as you can going to see that only 50% or less than 50% of those patients with hormone receptor positive received endocrinal therapy in this setting. So this again, it proves again and again that giving hormone receptors or endocrinal therapy is important in the metastatic phase maintenance after chemotherapy. So the other trial was to introduce trastuzumab deruxtecan in the first line. So we have seen that it had good efficacy in the second line versus TDM1. Why not to put it in the first line in combination, either alone or in combination with pertuzumab? No chemotherapy here because trastuzumab is actually a combination of chemotherapy plus antibody. It's an antibody drug conjugate, and this is a hierarchical design. It means that they needed to prove that TDXC plus pertuzumab had a good efficacy before looking at the arm of trastuzumab deruxtecan alone, and you can see that we have a progression-free survival benefit, and it's mild improvement in objective response rate, but yet no overall survival benefit was seen, but it's too early. We need a longer follow-up to see and detect the overall survival benefit, and we can see also a PFS2 benefit, so crossing to trastuzumab deruxtecan didn't change the PFS benefit we have seen with the first line addition. So the algorithm of management of this patient, still we have trastuzumab plus pertuzumab. So the 𝐏𝐫𝐸 protocol is the standard of care for those patients, maybe with the addition of palbociclib for those patients who have hormone receptor positive. Definitely you need to add endocrinal therapy. This is the most important, and maybe coming soon the addition of trastuzumab deruxtecan instead of trastuzumab and the taxanes. Definitely the standard second line now is trastuzumab deruxtecan. Third line you can have, according to the 𝐏𝐸𝐸, tucatinib, capecitabine, trastuzumab, or TDM1. Both are options in this patient. And then in the fourth and fifth line you can have margetuximab plus chemotherapy, trastuzumab plus chemotherapy. So we know from older trials that you can use trastuzumab beyond progression. When everything has failed, you change the chemotherapy backbone and you add trastuzumab. You have neratinib plus capecitabine, endocrinal therapy plus anti-HER2 therapy, and also looking at biomarkers by looking at NTRK, MSI, so the tumor agnostic indications for other therapies. In patients who have unstable brain metastasis, you may upgrade the combination of tucatinib, capecitabine, and trastuzumab, because we know that this is an agent that crosses the blood-brain barrier, have a very good intracranial efficacy, so it is going to be more appropriate than using TDM1 in the third line. The second line remains trastuzumab deruxtecan because it has also a very good intracranial efficacy. So as you have seen, what we have now, a very established for a long time standard first line protocol, which is the 𝐏𝐫𝐸, and then we have TDXD coming very rapidly in all the settings, in the neoadjuvant, adjuvant, and also it is now the standard second line, and tucatinib, which is the joker for those patients who have brain metastasis. Again, remember the interstitial lung disease, the ILD. Again, being a good oncologist and being a good doctor is not knowing how to look at the guidelines and choosing the drug, but it's about how to manage the toxicity, prevent the toxicity of your patient. And again, I will close my message with the initial one, which is preserving the sample. Tissue is the issue. It is a very old message, but it never gets too old. Thank you very much.
Thank you, Professor Khaled. I think the message is very clear concerning HER2 positive breast cancer patients, and